Hello friends, this is a case of laparoscopic cholecystectomy and bilateral salpingectomy. This patient sister was suffering from the ovarian cancer. So, she want risk reduction bilateral salpingectomy. So, because BRCA1 mutation was there in the family. So, here we are applying 2 alleles forceps on either side of umbilicus, and inferior crease of umbilicus we will use to introduce the varus needle and the trocar. So, this is the 11 number of knife, and we are stabbing the inferior crease of umbilicus, and after that we will hold the varus needle like a dart, and we will measure the thickness of abdominal wall, and thickness plus 4 centimeter of the varus needle should be naked, and then we will put the varus needle into the wound and lift the abdominal wall, and varus needle should be introduced in such a way that it should be perpendicular to abdominal wall and oblique to the body. As always we are saying that if it is perpendicular to abdominal wall, you will not have a risk of going to the preperitoneal pocket, and this is the irrigation suction and hanging drop test. This is the hanging drop test, which the ball is sinking and the hanging drop is sucked in. After that we will attach the tubing of insufflator. Here we are using the preset pressure 15 and slowly flow rate is 1 liter per minute. So, this is a case of laparoscopic cholecystectomy, and with the same port we will do bilateral salpingectomy. We will not use any extra port. So, patient undergoing this surgery, because sometimes some of the patients are afraid, and especially if in their family there is a confirmed BRCA1 or BRCA2 mutation carrier, then after family history they want just risk reducing salpingectomy. However, we will not remove the ovary hair because she is young patient, but family is complete. So, that is why we will do it on the means patient voluntarily want this procedure. However, it is not a fully confirmed risk factor, but in the literature it is proved that in the patient who has the pathogenic BRCA mutation, they should get a bilateral salpingectomy after finishing the family. So, here we are giving the inferior crease of umbilicus, a smiling incision, and after we will put the optical port, that is a 10 port. So, this is inferior crease of umbilicus, and after that we will dilate the wound so that we can enter into the vitreointestinal tract. That is a part of a Scandinavian technique, and then we will put the port. Head of the trocar should rest over thenar eminence, middle finger should wrap around the ear inlet, and the index finger should be pointed towards the sharp end. We always put little betadine. If you will search the Google and you will type in the Google that dipping the tip of the trocar with the betadine, one big study was published where they have seen that the port wound infection can be minimized before putting the trocar if you will dip it into the 10% povidone iodine. So, this is the hissing sound, and now the trocar is taken out and the telescope will be introduced. We are connecting the gas again, and the maximum flow rate will be increased to 10 liter per minute. After that we will have a first view of the gallbladder. Then this is the palpating the G sternum, and just half centimeter below the G sternum we will put the epigastric port. That will be our main working port. Right handed instrument will be used from this port, like harmonic, hook, or like a shore, or whatever active instrument you will use. So, this is the 10 port again, and initially it should go perpendicular, and then you can puncture the membranous part of falciform ligament, and this will be the second port. Now, here assistant is putting the third and the fourth port. Third port will be mid clavicular line just below the costal margin, and that will be 5 mm. So, assistant who will hold the fundus of the gallbladder, you can give him the opportunity to put this third port, and then again fourth port should be 7.5 centimeter lateral and 7.5 centimeter below the third port, or you can use at the level of umbilicus, and this will be at anterior axillary line. So, once all the port will be introduced, then you can put the patient head up and right up, so that left lobe of the liver will go away, and it will be easy to retract the fundus of the gallbladder towards the right shoulder. So, this is the fundus grasper. So, we were talking about the BRCA risk reducing surgery. So, in these patients basically testing should be considered through a genetic counselor or hereditary cancer clinic before making the decision of doing salpingectomy, but she was so afraid, so she voluntarily want that tube should be now removed, and she no more want baby also. So, she want tubectomy for a purpose of sterilization also. So, this is the posterior peritoneum is dissected above the Rouvier sulcus, and now anterior peritoneum is also separated, and then posterior window is formed. Here we can see inferior surface of the liver is visible, and now we will separate the visceral peritoneum over the cystic pedicle. Here little bit duodenum is pushed down, and this is a very simple cholecystectomy, and we can see cystic pedicle skeletonization is over. After that, we will make a Maryland, and we will make a posterior and anterior window, and we will define the critical view of safety. So, always open the jaw of Maryland parallel to the tubular structure, and this is the posterior window conform, that is in between the artery and liver, and this is the anterior window which is in between the artery and duct, and we can see critical view of safety will be established. And here we will turn the ICG on, and we can see the CBD, common hepatic duct and cystic duct, and this ICG is conforming this T junction, and all the structures are clearly delineated and the safety is established. This is the CBD, this is the common hepatic duct, this is the cystic duct, this is the cystic artery, and all is done. After that, we will clip the artery first. Only one clip we are applying on the artery because we will use harmonic, and this is clipping the duct. So, 3 clip will be applied over the duct. Distance between first and second is 3 mm, distance between second and third is 6 mm. And now with the harmonic, we will cut the artery, and then we will cut the duct. So, laparoscopic cholecystectomy is very easy in this case because this was a simple cholecystectomy. However, she has multiple stone, and there was couple of history of cholecystitis. So, after that you will separate the gallbladder from the liver, keeping a good areolar plane, and the gallbladder is getting separated. Once you half of the gallbladder will be separated, then light cable should be put down, so that you can see the bed of the gallbladder, and this is the final separation of the gallbladder is done. After that, for salpingectomy, here we are using the striker mini alligator, which is introduced in between the pubic symphysis and umbilicus. These instruments are mini lap instrument which can directly go percutaneously. Many companies are making, a striker is making, this is the Teleflex, that instrument, that is also a good company, And this instrument has the advantage that you don't need port, it can be directly introduced percutaneously. So, suppose you are doing cholecystectomy, appendectomy, this is only 2.3 millimeter system, and directly once you will go it will act as a grasper, it has a needle, it has electrosurgery also. So, these are micro instrument which has an advantage that compared to 5 mm which need a port, these instrument directly percutaneously you can introduce, and it will act as a same grasper effect as you are using with the 5 mm instrument. So, here we will use the same instrument, and then we will do laparoscopic cholecystectomy by conventional way with the 4 port. After that you will put this the suprapubic in between the umbilicus and pubic symphysis. With these mini lap instrument, you can do 2 port cholecystectomy, 2 port appendectomy, 2 port hernia, and even in the salpingectomy also it can be used. So, we have already shown you in many videos how to do cholecystectomy by these instrument, but this time I am not showing you the cholecystectomy, I am showing you how to do salpingectomy bilateral using the striker mini elevator. Although this video which you are seeing, it is from Teleflex, this is one another company, and Indian companies are also making this type of instrument which is autoclavable and reusable. So, if you want you can perform the surgery by using 1 or 2 micro instrument. So, as you know that nowadays patient give a lot of importance to the cosmetic outcome of the surgery. So, you have alligator, you have a clutch grasper, you have a Babcock, you have a bobble grasper, which all are percutaneous instrument, and you have electrosurgical instrument as well, like probe, the needle, the spatula, and you can use it without any port. So, advantage of this is that it does not need any port, you can put percutaneously, and salpingectomy you can do within 2 minutes. Here with the lateral anterior axillary line port we are using ligation, and this striker mini alligator is a percutaneous instrument that is only 1.8 mm instrument which can be directly pricked with the abdominal wall, and then tube is given inferomedial traction, anteromedial traction, and this is the right tube being separated. So, this is very easy by ligation, and it is right salpingectomy is done. After that we will keep it over the Morrison's pouch, so that all the organ we will take it out at the end. Now, the right tube we have gone lateral to medial, and the left tube we are going medial to lateral, because ligation is in the right side on the right anterior axillary line. It is the same port which is used by the surgeons to hold the fundus of the gallbladder during cholecystectomy. So, this is the left tube, and we should try to remain as near as possible to the tube, so that devascularization of the ovary should not happen. So, this is the over, surgery is finished. After that we will put a claw forceps from the epigastric tube, epigastric port, and first we will remove both the tube, and after that we will remove the gallbladder. Epigastric port is 10 mm, so tube can be easily taken out, and then you will take the neck of the gallbladder with the claw forceps, and that also will be taken out through the epigastric port. So, this was just a simple case of laparoscopic cholecystectomy and bilateral salpingectomy, which was performed by the same port. So, thank you very much for watching this video.